In this video, we're going inside an outreach clinic in southern Indiana to look at their utilization of telemedicine. This clinic is different than a primary care clinic that might be located in an area where people have a fair amount of resources. We wanted to hear how telemedicine can bring access to care for patients that might live in more rural areas or might have some limitations with resources, but also how telemedicine may widen the equity gap because some of these patients do not have the equipment that they need or have the digital literacy to be able to interact with the device or the Wi-Fi networks to be able to have a successful visit. So this particular clinic is a successful telemedical clinic, but works a little bit differently. Take a look.
So my name's Jericho Andrews. I'm a linkage to care case manager here at Positive Link IU Health. My role is to engage with folks, find folks who are HIV positive and aren't connected to infectious disease care or care coordination.
I'm Alex Fort. I am an HIV educator and tester. So I go out into the community, I go to groups that are at risk for getting HIV or Hep C, most bloodborne infections that are extremely common in the state.
So my name is Kristen and I work in the Terre Haute office with Positive Link, and I am the hepatitis navigator.
Positive Link in general, our goal is to eliminate barriers to care because life gets in the way of everything, including the most vital things like our health care. Some of our folks struggle with intellectual disabilities. They struggle with housing crises. They struggle with homelessness. They struggle with domestic violence situations.
They don't have reliable phones, they have reliable addresses. They don't have access to email unless they go to the library if they're allowed in the library. And without a reliable address, you can't get medication shipped to you. It's a whole lot of issues.
I am with obviously smaller country areas. So they don't have the capability of even transportation to even be there to sit with you in the office to do that intake. So I basically sometimes just do intakes with the clients over the phone because I'm not always face-to-face with them because of those gaps in services. We have to put their information into Cerner and then also Avizia, which Avizia is the resource that is able to connect the tablets for that video conference.
One of the things that I really value about telehealth is outside of just Positive Link here in Bloomington is our ability to provide choices for folks in other regions. Like, it's difficult to empower people around their own health when they can't make choices. And in places like Bloomington and Terre Haute especially, if there's only one provider that you can connect people to, there isn't choice. It's really hard to provide a choice when there aren't choices. It's hard to empower someone when they don't have options. So I think that really, really helps our folks feel like they're kind of in the driver's seat with their own care.
So the work that I do is primarily going to where the people are. A lot of the work that we do is in like addiction treatment centers. We go to the park, like Seminary Park. We go to schools. We're on campus. We basically get around almost everywhere that we're allowed to be.
I'll follow up on referrals that we get. I'll do some investigation in terms of like hospital reports for folks who are inpatient, and find folks who are eligible for our services and in need of our services. And I kind of go out and do the initial engagement, the initial interviews, do the initial kind of rapport building.
A lot of times we tell them where we will be at. And so for the park, we don't just randomly go. We go every other week, like on Monday at the same time. We have a bright yellow tent. It stands out. We have permission from the city to do it. So it's not even like guerrilla care. It's coordinated, and so a lot of times people know that that's where we're going to be, and that's what we have with us, so if they need it, they can come get it. So while we could go to Shalom, we could go to Friend's place, we actually go to the park where they're at, and we go to a place that's visible and easy to access.
There's a lot of things that a client faces that they wouldn't want to come in to get a test or be seen getting a test done. Right. So I think it's great that as long as the resources are offered and they know where to go and are comfortable that they can talk to you, one time, like, you're saving a life. Whether it's one person, 5 people, just give them time.
when I get a referral, sometimes it's as easy as I'll get a phone number, I'll make a call, I'll meet up with folks, and everything's great. Sometimes I have to kind of go through different databases that we have access to, like Cerner, the Medicaid portal. Sometimes I'll have to kind of look through people's legal history to see, if there are addresses that I can kind of look at. Some folks, it's just a matter of knowing that they are homeless or couch surfing, and that they may be in a certain spot at a certain time. They may go to Shalom for lunch. They may go to Community Kitchen for dinner. They may be at a certain campsite, and so it's a little bit of just kind of trying everything, Sometimes I'll do, I'll research people on social media and research family members and then try to triangulate in that way, and it's a little bit of detective work for sure.
I know that every case manager here goes out a long, long way to make sure that people get the care they need. Even if that involves literally going to the client with everything that they need and then bringing the client back. We will find a way for them to get here to make their appointment. We will find a way holistically that works within their parameters.
And a lot of times you are their only support. So, for us, we do have that system at home. For the clients that we give care to, we are everything that they have. And definitely linkage to care, because when they do fall out of care, sometimes they'll show up in emergency rooms, and linkage to care is able to contact them and pull them back into care.
Aside from the linkage to care and just contacting people, bringing them in, I also serve a supplemental role, so I kind of can provide additional case management support to folks. And what that looks like for some folks is kind of just a familiar person in unfamiliar spaces to help them listen, to help them reflect, to help them remember. And so when somebody comes into the telehealth clinic, for example, I'll bring them in, I'll walk them through the door, I'll help introduce them to their case manager if they haven't been introduced, and I'll help connect them to the telehealth appointment.
But this is the kind of work where I feel useful, and the information I have is desirable. I don't feel like I'm proselytizing. I feel like I'm providing the service that people actually want me to provide. I'm not selling anything. I don't get commissions off the number of tests I do. I just like it.
I work here because I'm drawn to the wraparound support that we're able to provide. I'm drawn to the team effort, the team approach to meeting people's needs, and everybody trying everything we can, pushing ourselves as much as we can to meet people's needs to get them into care.
Notable thing about this video is that they don't talk about telemedicine. They talk about getting patients in and engaged. Telemedicine is the resource to connect with the doctor, but the work is getting the patient in and engaged in services. It's not about the technical part of the encounter. It is establishing that trust to make sure the patient feels comfortable even showing up.